Everybody, so I've decided to update the full thickness burns video to make it more updated for 2025. So here we go, new and improved video. So let's talk about this. Full thickness burns are also referred to as third degree burns. So I know a lot of people are just like, oh, like I had a second degree burn or a third degree burn or whatever. I guess not casually in conversation, but y'all know what I mean. Colloquially, those are what that is referred to. So full thickness equals third degree burn. So let's talk about it and kind of talk about some anatomy associated with it. So with burns in general, it's really important to understand anatomy. So as we burn the first layer of skin, the epidermis, the top layer, that's going to be a first degree burn. As we burn the second layer of skin, the dermis, that's going to be a second degree burn. As we burn the third layer of skin into the subcutaneous tissue, or subcutaneous space, that is going to be it's also called the hypodermis in some piece of literature. Third layer skin, third degree burn. When you think of it that way, not too difficult. So with a third degree burn, epidermis gone. Dermis gone. Subcutaneous tissue, it's now exposed. So in the subcutaneous tissue, tons and tons of fat, adipose tissue, and all of that is exposed. Our free nerve endings, aka our nociceptors, those are our pain receptors. They are gone. They have been burned away. Why have they been burned away? Because they're located in many parts of the dermis and everything. Once we get to the hypodermis, aka the subcutaneous tissue, they gone. So actually, if you like are touching in the center of the burn, it doesn't hurt. It's the outside parts of the burn that hurt because those are not fully burned. Um, so yeah, there's no pain receptors in the actual burn itself. So we're looking at this, like there's a whole chart that shows all the different types of burns. So third degree, we burn through the epidermis, we burn through the dermis, we've gone all the way down to the subcutaneous tissue. So complete destruction of the epidermis, complete destruction of the dermis, free nerve endings are gone, our subcutaneous tissue is gone. And so let's talk about some of the etiology associated with it. So there's different types of burns. As we probably know, we're most familiar with thermal burns. So fire, hot water, steam, all those things can all cause us to have burns. That's like the most common one we think about, but we also forget that there's also electrical burns, which can also cause heart arrhythmias. So if somebody is burned or electrically, we always have to make sure we're checking their heart rate rhythm because they could end up developing arrhythmias or their heart could stop. So it's something to take into consideration if that's the etiology of this person's burn, checking on their heart. But yeah, electrical burns happen. Getting shot, getting struck by lightning is the most aggressive one. But water plus electricity in any capacity, sticking is getting stuck in a socket, short circuit electrical, an arcing of the electrical current and everything. All that can burn people. So burns are more likely to happen to individuals actually over 70. And this is because these individuals, like the third degree burn, is more likely to happen to individuals who are over 70. And this is due to the fact that with the elderly population, their skin is like thinner. So it's basically mostly because of this thinner skin is like a biggest reason for as people get older, their skin is just not as pliable or anything. So these layers are easier to penetrate through to become a full thickness burn. That's why it's more common. Also, individuals who are older tend to have more mistakes of like leaving on stoves or something of that nature, turning something, getting hit by steam. Like there are more burn things that I've seen happen with individuals who are older. I've seen a lot of like women actually burn themselves with like hair curlers or flat irons or stuff, or even like getting too close to a what's it called? A hair dryer, and even like sitting on heated blankets or using hot packs or stuff like that. If I'm 28, but I don't know if you guys like when you were younger, you had your mom's like hot pack that like doesn't turn off automatically and it gets to the temperature of the sun, which was like great if you had period cramps, but like stuff like that still exists and people use them because they've had them since the 90s and those can burn people. So that's a big thing. Again, those would be less likely to become a full thickness burn, but again, older individuals are likely to burn. Males are also more likely to get burned than females. Why is this? This is not to be rude. This is not to be aggressive. This is to help you remember things. Teenage boys do stupid shit. That is the easiest way I can remember that younger male populations are more likely to have a lot of problems like spinal cord injuries, TBIs, burns, all of that stuff. They're also more likely to be working in these situations, such as with fire, like firefighters and electrical electricians are more male-dominated fields. You would see more men in them, higher risk, again, more likely chance of getting injured. So, not sexism, just pulling up the research, the statistics, the rates. So, again, kind of important to know the etiology just so then, like, when you see a patient pop up with this, you're like, okay, they're fitting the patient profile for this. This makes sense. So, that's just something to take into consideration of like who's more likely to get burned. Hopefully nobody's getting burned, but oh, jump scare, here's a burn. I hope you knew that this video would have pictures like this. Or if you're listening to this on a podcast, I hope you knew that we were gonna describe them in detail. But let's talk about it because the description is a big thing for the boards. The boards is gonna be like, can you know based off of a description and based off of what we're telling you what kind of burn this is, and then classify the burn, or if we're already talking about the classification of the burn, do you understand what is happening? So let's talk about it. With a full thickness burn, the epidermis has no fluid in it. But the dermis, that's our weepy layers. Like we get blisters and stuff and whatnot. That means we've gone through the epidermis. We're now in the dermis. The dermis I like to think of as it's very juicy, okay? When we have a full thickness burn, we have burned through the dermis. So it's gone. So bye-bye. So all of our juiciness and like fluid areas of our skin is gone. Now it's just super dry. So little to no exudate. It's very dry. To me, white coloring because again, we've gone all the way down to our adipose tissue, our fat tissue. If you have ever done a dissection or like seen somebody doing surgery, like fat tissue is like a yellowish, whitish kind of color. So again, this picture here, perfect showing just it's like a very like whitish kind of yellowish color. Um, Almost kind of looks like snot kind of colored. That's the best way I can describe it. But yes, it's going to be that lighter in color. Again, there can be areas where the tissue has died completely, so that would be blackened areas. So where you could have some necrosis going on. There's also more red in areas, especially as you get towards the periphery. So like in this individual here, if we're looking at this picture, if you're able to see it, we have this redness that's right along the outside of it. Again, that redness actually is pretty much showing that these are like second degree into first degree burns on these sides, right at the edge, because again, burns aren't beautiful. They are jaggedy, weird shaped. It'd be like that. So again, you'll see areas of erythema, which is reddening of the tissues. So again, we have this exposed subcutaneous tissue, making it that yellowish, whitish color. The nerve endings are gone inside. So if I'm where my cursor is, if I'm poking right there, first of all, that's rude. I better have gloves on, but if I'm poking right there, they actually can't feel it. So there's no pain inside the burn. And those outsides where it becomes like a secondary, those are very, very, very painful. That's why people in burn units are screaming. If you've ever been on a burn unit, first of all, you never forget the smell and you can never forget the screams. It is not a good place to be. But we have physical therapists that work there because they help preventing contracture. So contractures tend to happen of this surrounding musculature. That's a big thing. That's why we're splinting with burns. I'm sure you've heard of that. We'll talk about that in a moment. You also have this risk of hypovolemia. So what does hypovolemia mean? Hypo being low, volemia being vol being volume, and then emia being blood. So low volume and the blood. So low blood volume. This can is also can cause hypovolemic shock. So again, that can cause problems with like going to organ failure basically. So again, there'll be an electrolyte imbalance. The patient's going to be dehydrated. So again, we're going to have to make sure that they're going to be on fluids for this as well. So don't be surprised they're attached to an IV with that. So it's going to affect their urine output, going to affect their kidneys. Just being aware of that to make sure that the patient's not going into any problems as you're trying to work with them. They cannot regulate their temperature, so they'll either be super cold, super hot. It's because all their temperature regulation areas have been burned off, so they just don't know. And the skin acts as a protective insulating barrier, so a lot of these people get really, really cold. So take that into consideration. They'll have difficulty breathing, especially if it's affecting areas on the chest near the lungs. Their skin can't expand, their lungs can't expand. It can definitely cause some problems, and then I also could run into the problems with shock as well. So the patient also might have some changes in their cognitive status. Usually this is happening because we're losing blood volume and getting dehydrated. So being aware of that, but again, patients at a very high risk of infection. So again, with any time that we have the skin barrier broken, the patient could become infected, get sepsis, and die. That's what the boards always think. So keep that in mind. Biggest priority you would want to see with this patient. So if you're observing them, you see that they look like they have signs of infection. We get that taken care of right away. I don't care if it looks like their contracture of their arm is all the way up here and it looks funny and it's like pushing into their face. If they look like they're infected, that's the bigger problem. Who cares about the arm? Cut it off. Actually, don't actually, but infection is the number one thing. So that's why I have that in highlighted yellow because that's one of the most important things. So being aware of that, patient might be on like IV antibiotics. You're going to be taking precautions, wearing gloves and a mask and everything to protect the patient from you. So how are we treating it? So again, if the patient's burned, the first 3 days, probably in the ICU, we're going to work on stabilizing the patient, get their blood pressure okay, get their electrolytes, kidney function fine, temperature okay, making sure they don't have a fever or they're hypothermic or anything like that. They're going to probably be getting skin grafts. So there's tons of different types of skin grafts, which is really cool. They can do some with like fish. I've seen that. But they have so many different types of skin grafting. So again, we're going to do skin grafting. We might have some splinting going on. So usually as PTAs, we're not creating splints, but we're going to be working with patients with splints. So knowing like, okay, that makes sense why they have this splint. So knowing why somebody would need certain types of splints, that's something we should know. If you're in my course, I have another video on splinting, but if you're just watching this on YouTube, I'm sorry, it's hidden. It's top secret information. Just kidding. It's in the score builders book too. So splinting, not too crazy. The biggest thing is just like, okay, splint it in a way where it's not going to become contracted. So like splint it in a way that stretches it. Makes sense. If you don't want a knee flexion contracture, you splint it into extension. Thinking of it that way makes a lot of sense. So with this patient, again, we're working on decreasing risk of contractures, protecting the skin, super important, making sure that's number one priority. Working on mobility, ambulation, flexibility. Again, this is not somebody you want to sit around because their skin's already fragile. So you don't want them to get pressure ulcers or anything like that. So get them up, get them moving. They say if you sit like a chair or sit in a chair, you'll start to look like a chair. So you can get some hip flexion, knee flexion, contracture. So keep them moving. Generally, we're not seeing the patient until like they're stable, so like 5 days after their burn, because then the PT's got to eval them first and everything. So we're not seeing them for a little bit. But energy conservation techniques, pacing techniques, because they're struggling with that, like hypothermia sometimes. Slow positional changes because of the hypovolemia, very, very common for this patient to get orthostatic or postural hypotension. So just take that one step at a time. They might end up needing a tilt table. Compression garments. So if you've seen this, it's like got the compression garments are like those like really like those brown looking ones. You've probably seen them for people's face and stuff like that, but they're wearing these for like up to 23 hours a day. So it really helps them with getting the skin grafts to hold, decreasing the edema, all that sort of stuff. So it's very important that the patient has this. Once they're fitted for those, they're wearing those like pretty much all the time. Like we're just checking the skin to make sure it looks okay. Cool. Keep that garment on. We're doing things. Once the skin graft is better, then we're kind of going to like once they have like a graft that's taken hold and they're more in that advanced stages after the burn, then we're working on getting them back to a strength and conditioning program to return their functional activities. Maybe they work as an electrician. They're like, yo, I want to get back in there because that's all I know. Some people might be like, that's crazy, but like you got burned. They're like, but that's all I know. Cool, awesome. Let's get them back to being able to do that. So once everything's stable, we're in those chronic phases of the burn, then we're back to like a normal strength and conditioning. But once everything has taken hold and it's doing good. So keywords, the epidermis and the dermis are gone. The subcutaneous tissue is exposed. We want to avoid infection and avoid hypovolemia, so making sure they have plenty of fluids and watching for that orthostatic hypotension and stuff. Painless within the wound site. So when you touch inside the wound site, there's no pain because the nociceptors are gone, aka pain receptors. Splinting and positioning to avoid contractures. Key. Also avoiding pressure ulcers. The area will be white with pink edges and it will be dry, so no exudate. So understanding, as I said before, how it presents the characteristics, super important. Okie dokie, friends. So we have our sample question here. A physical therapist assistant is treating a patient, treating a full thickness burn victim at an inpatient facility. Again, you'd probably say a burn victim with full thickness burns nowadays, but whatever. Y'all know what I'm saying. So we got somebody who's got full thickness burns in an inpatient facility. The patient has been immobilized for some time and is in a negative pressure room to help facilitate wound healing. Which of the following findings would be most concerning for the physical therapist assistant to observe? Okay, so we're looking for a scary thing. 1 equals blood pressure of 105 over 65 and sitting. 2, patient demonstrates contraction of the hamstrings limiting knee extension. 3, patient demonstrates a fever of 40 degrees Celsius. Or 4, patient unable to feel sensation inside of the wound bed. So I'll give you guys a second to think about that. Okie dokie, guys. So the answer is patient demonstrates a fever of 40 degrees Celsius. So if you're like with Bree, we live in the land of the free, home of the brave, rah rah, eagle screech, USA, USA. Why is there a Celsius there? Well, I'm sorry. In medical world, we use lots of metric land stuff. So 40 degrees Celsius, the important thing to know is that 30, like 37-ish is degrees Celsius is going to be our 98.1 degree or 98.6, sorry, degrees Fahrenheit. So 98.6 degrees Fahrenheit is about 37 degrees Celsius. So if we're at 40 degrees Celsius, that's not good. Honestly, that's like 105-degree fever, something like that. It's not good. I'd have to look up the exact conversion, but somebody had this in a case study, so somebody has reached this before, but it's not good. Basically, the big thing that we need to know is that 37 is normal. Anything above that is a fever. Anything below that is hypothermic. So again, any patient who is going to be having a fever, that indicates infection. Remember, the boards cares the more about infection versus your arm or your leg. So blood pressure 105 over 65 and sitting. Okay, like I see people who weren't burned who have that. Like it's just a little bit lower blood pressure, but like that should be enough that they're not passing out. Like if we're worried about them passing out, it's under 100. If that top number is over 100, we're not worried about passing out. So again, just a little bit lower blood pressure to be expected with this patient. Completely explainable, should be able to be fine. Cool. Demonstrates a contracture of their hamstrings, limiting the extension. Okay, this is concerning. We want to fix this. This is like more concerning than number 1. It's going to really mess with their ability to walk and stuff like that. But let's keep going. The fever one, okay, even if you weren't sure that 40 degrees Celsius was like a fever and you got all tripped up on that because you're just like, USA, USA, we use Fahrenheit. I put fever in there. I gave it to you guys. I put fever. I was nice. So fever is bad. Fever is always concerning. So even if you weren't sure of the the metric system numbers, fever is always bad. And then number 4, patient unable to feel sensation inside the wound bed. That's typical. That would be expected with a full thickness burn. So again, fever, bad. That one we need to address immediately. Like that's like, okay, we need to get nursing. They have a fever. We need to address this. PT on hold. We're going to address this fever. Maybe they need antibiotics or something. So good to note, what are the concerning things? What is the most priority? What are things that we're worried about? What are things we're less worried about? That's why we take this test, because if you're like, oh, that knee contracture, that's a problem. Let me stretch them out. Okay, well, you spent a whole 40 minutes working with this patient, stretching them out and stuff like that. Their fever is getting worse and now it's spreading through their whole system. It's like, okay, like we can worry about the knee later. We got to make sure our patient doesn't die. All right, friends, hopefully this was helpful, and I'll see y'all in the next one. Thanks for letting me update this video for y'all.